السلام عليكم ورحمة الله وبركاته. معكم أحمد الحماد. Today, inshallah, we'll be talking about inflammatory bowel disease diagnostic steps. So, briefly, IBD is a chronic inflammatory process affecting the whole body, but mainly manifested by GI manifestations and symptoms, and is divided into two main conditions: ulcerative colitis and Crohn's disease. Okay, the differences between the two conditions are very long. فالفكرة من التشخيص إن الاي بي دي ما في لها تيست معين واحد. إذا كان بوزيتيف أعتبر هذا البيشنت عنده اي بي دي، وإذا كان نيجاتيف أستبعد الاي بي دي. So its diagnosis is like building blocks to your confidence that this is IBD, and these blocks are from the early history and physical exam findings up to the most invasive endoscopy investigation. So we'll go through these steps and find out what are the findings that are suggestive of IBD diagnosis in each step. فنبدأ بالclinical picture present with very wide range of symptoms and signs, and you can divide them into intestinal and extra-intestinal manifestations. In the intestinal is any of the GI symptoms, and none of them is specific for IBD. In the extra-intestinal, you have these manifestations. You can divide them according to the organ, like you have eyes, skin, joints. So in the eye, you may have uveitis or episcleritis. In the skin, you may have erythema nodosum or pyoderma gangrenosum. In the joint, you'll have the seronegative spondyloarthritis associated with IBD. So chronicity is an important feature, so differentiated from acute conditions affecting the GI symptoms like acute gastroenteritis, for example. Also, you may find weight loss, malabsorption findings. So these are all suggestive IBD. So you'll go to the next step, which is the lab testing, and find out if there are any other blocks preferred for the diagnosis of IBD. So you start by CBC. You have the hemoglobin in the CBC, WBCs, and platelets. Platelets and WBCs are inflammatory markers, so they're expected to be elevated in case of IBD. Hemoglobin is expected to be low, anemia, and can be due to different possibilities, either iron deficiency or B12 deficiency. Iron deficiency may be a result of malabsorption or chronic blood loss associated with IBD as lower GI bleeding. B12 deficiency is usually secondary to the malabsorption, and especially in Crohn's patients. The terminal ileum is the most affected part of the GI in case of Crohn's. So these are the findings suggestive of IBD in CBC. Regarding the ESR, CRP, also expected to be elevated as they are inflammatory markers. General, non-specific, can be elevated due to any condition or any inflammatory process affecting the body. Regarding the serology, we have two important autoantibodies, the ANCA, ANCA, and you have ASCA. ANCA is usually elevated in case of colonic inflammation, which is more specific to ulcerative colitis. ASCA, on the other hand, is more elevated in inflammatory process affecting the small bowel. So it's more specific to Crohn's disease. So these autoantibodies are sort of specific to each condition, but are not sensitive. So if these autoantibodies are negative, they will not rule out the IBD diagnosis. But if they are positive, they'll build another block suggestive of IBD. And finally, we have the stool inflammatory markers. Stool inflammatory markers, we have lactoferrin, and calprotectin. These are important in differentiating IBD from irritable bowel syndrome. So if these are elevated, they're more suggestive that this is IBD rather than IBS. Also, another part of the stool examination, looking for OVA toxins like C. diff toxin, any chronic parasitic infection or bacterial infection to be ruled out, as the clinical picture of IBD, as we mentioned before, is not specific, so you have to rule out infection. فهنكمل بالنسبة للإيميجينج. الإيميجينج is not very essential for the diagnosis of IBD and is more important in Crohn's than ulcerative colitis patients, as the small bowel is more affected with Crohn's and is not accessible through the endoscopy by upper or lower interventions. So we have different modalities. We have the X-ray abdomen, barium enema, and CT or MR enterography, magnetic resonant enterography, which is the most sensitive for the evaluation of IBD patients. Actually, X-ray is important in ruling out other differential diagnoses, as IBD may present as emergency acute condition and must be differentiated from other conditions in acute abdomen. Barium enema is also an option, but now CT enterography or MR enterography is more used. Here are some of the findings of X-ray abdomen for patients with IBD. You can notice these opacification around the wall of the colon, all over the colon. These lines, these are called thumbprinting, and are due to the wall edema or secondary to the inflammatory process. Here also we can see this thumbprinting all over the wall, and also the bowel. This is the transverse colon is dilated as well, and we have the 3, 6, 9 rule for bowel dilation. Small bowel should be less than 3 centimeters, large bowel should be less than 6 centimeters, and cecum and sigmoid should be less than 9 centimeters. Here's the barium enema. You can see the granularity of the colon wall, which represents the inflammatory process going on in the colon, and also there is loss of hostral marking that are usual in colon. They're usually like, the hostra are usually like this. So in the process of inflammation, this hostral marking is lost. And finally, we have the endoscopy, which is the most essential step for IBD diagnosis, ruling out other differential diagnosis and differentiating ulcerative colitis from Crohn's disease, either from the visual appearance of the inflammatory areas or from the biopsy taking during the endoscopy. We'll go through some findings. You can see this longitudinal ulcers affecting this part of the bowel right here. Here's the typical cobblestone appearance of the bowel in case of Crohn's, and here's aphthous ulcers throughout the bowel. It's noted here that all children and almost all Crohn's disease patients must have upper GI endoscopy and biopsy to complete their staging as well. And here we have the ulcerative colitis endoscopy finding, ranging from mild granular erythematous surface into the most severe hemorrhagic condition. So it's a very wide range of manifestations. You can find ulcerations right here, erosions, and also you have this post-inflammatory pseudopolyps, which are found in ulcerative colitis patients. Here are some of the microscopical findings of IBD patients. In case of ulcerative colitis, the ulceration is usually confined to the mucosa and associated with the crypt abscesses and loss of goblet cells. While in Crohn's disease, here you can see this fissuring ulcer affecting the whole mucosa, and actually the inflammatory process may extend into the whole wall of the bowel in case of Crohn's. So it's a transmural, may cause strictures or perforation to the wall, and associated with non-caseating granulomatous inflammation as well. Thank you.